So next off we have Catherine Muir. So Catherine's a Paediatric Intensive Care Physiotherapist at Women's and Kids Hospital in South Australia. She's got 10 years of clinical experience and has completed her graduate diploma in public health. Thank you, Catherine.
Okay, thanks for having me to present today.
Hang on a second.
Beautiful, thank you. So thank you for having me to present today. Today I'm going to be presenting on a staff survey we conducted earlier this year looking at barriers to early mobilisation in our Paediatric Intensive Care Unit, the outcomes of which we're using to help plan a practice change around early mobilisation in our PICU. I'd like to acknowledge and thank Kazuhiro Maki, Dr. Subodh Ganu and Dr. Steve Kearley for their contributions to the project, and also to thank Simone Defoe for allowing us to modify her existing questionnaire for our purposes. So, to give you a snapshot of PICU today, survival has improved with mortality rate of just 2.5%. And with this, we've seen a shift in the literature to looking at the short and long-term outcomes for children following a PICU admission. Whilst there's increased reporting of critical illness sequelae in children, there are challenges in the assessment of this. So we see with the heterogeneity of our population, there are broad ranges of ICU-acquired weakness and delirium reported. However, what we do know is children can experience a broad range of developmental sequelae following a PICU admission. This can impact on their physical, cognitive development and mental health. It's well established in the adult ICU literature that early mobilisation results in improved patient outcomes in both physical and cognitive domains. There is now emerging evidence in paediatrics for the safety and feasibility of early mobilisation, and practical recommendations for early mobilisation in PICU were developed last year by Chung et al. Barriers to early mobilisation in PICU echo those reported in the adult literature. However, there are some barriers unique to our PICU population. We have an incredibly heterogeneous patient population with varying ages, sizes, disability and comorbidities. Family involvement is essential for some patients. We really need it to ensure patient cooperation with mobilisation interventions. And there's a lack of paediatric-specific guidelines when compared to the volume in the adult literature. It's important to acknowledge that these barriers, properly addressed, can become facilitators for early mobilisation. So we're a small unit at the Women's and Children's Hospital. We have 12 physical beds with funding for 6, with numbers fluctuating seasonally. We're a tertiary teaching hospital with a level 5 PICU. We have 6 consultants, 70 nursing staff and 2 physios covering 1 FTE and a number of physiotherapy staff that cover the weekends. We're very fortunate to have a stable staff base with almost all of our nursing staff being highly experienced and having worked in the unit for years, and we have a strong focus on family-centred care. So to give you an overview of our survey, we conducted a paper-based survey with medical, nursing and physio staff currently working clinically in the unit on a regular basis. I and the other early mobilisation team members handed out the surveys face-to-face over the unit over a 6-week period, and the surveys were returned anonymously. The survey was conducted with the approval of the Women's and Children's Human Research Ethics Committee and was based on one developed by the physio at the Royal Adelaide, Simone Defoe, and modified with her consent, then piloted with the Women's and Children's PICU research group. Early mobilisation in PICU was defined on the cover sheet as mobility interventions commencing within 2 to 5 days of ICU admission. This may begin whilst the patient is still receiving life support, e.g. mechanical ventilation, and varied mobility interventions suited to different patient ages and stages of development were outlined. Most questions were answered on a 1 to 5 Likert scale and were divided into 3 sections: patient-related, institution or unit-related barriers, and other barriers. We had a total of 47 responses, which was a 77% response rate, with 68% of respondents having mobilised a patient in the last fortnight. Largely it was nursing staff that responded, as they make up the largest number of staff in the unit. And the response rate for medical staff was low due to a number of workforce issues in the department at that time. So they were included in the overall data but unable to be analysed independently. So this graph compares the three domains of the questionnaire: patient-related barriers, institution or unit-related barriers, and other barriers, which related more to how we value and communicate about early mobilisation in our patients' care. I've used red to represent major barriers, blue to represent no barrier, and grey moderate. The data labels give you the percentage of responses. You can see that patient-related barriers are far more skewed toward major barriers, whilst institutional cultural barriers, respondents generally felt there were fewer barriers to early mobilisation, whilst other barriers sat much more in the middle, moderate barriers. I'll go through some of the questionnaire data from each domain in more detail now. So patient-related barriers were generally perceived to be the major barriers to early mobilisation. Hemodynamic instability, instability on respiratory support, and risk of extubation or decannulation were viewed to be the most significant barriers to mobilisation. To me, this demonstrates the need to develop some guidelines and stepwise approaches in terms of how we approach mobility with our patients. Risk of vascular access dislodgement was also viewed to be a significant barrier to early mobilisation, with 63% of respondents believing it a major barrier. For me, this was unexpected, as there's a large body of literature on mobilising people with a variety of different vascular access. So I wanted to take a look at this question a little more closely, and there was a clear difference between nursing response and physio response to this question. Most physios weren't particularly concerned about the risk of vascular access dislodgement with mobilisation, whilst nursing staff were, and I believe this may be due to our differing skills and knowledge and roles and responsibilities in PICU. So moving on to institutional unit cultural related factors, staff generally felt that unit culture and structure provided fewer barriers to early mobilisation. Whilst overall staff felt there was a willingness to help with mobility interventions, there was greater challenges with staff being available to assist. Staff had varied views on the expertise and knowledge around early mobilisation in the unit, and whilst it didn't provide as big a barrier as some of the patient-level barriers, almost half of the staff acknowledged that their or their colleagues' lack of expertise or knowledge was at least a moderate barrier to mobility. Equipment availability was not viewed as a significant barrier, and as physio for our PICU, I have a significant role in sourcing appropriate equipment for our patients and do experience significant challenge around this. So this was something I also wanted to look at a little more closely. And comparing the physiotherapy responses and nursing responses, I found that physios reported a much higher level of barrier when compared to nursing staff. Again, this reflects our differing roles and responsibilities and knowledge of varied resources available for mobility. This also suggests to me that equipment may be an ongoing challenge, with a large proportion of PICU staff not perceiving equipment availability to be an issue, thus there's less incentive to acquire more equipment, and allied health not viewing certain items of equipment to be allied health therapy specific, such as appropriate post-operative seating. So finally, here's a summary of the other barriers to mobility. You can see that staff responses generally sat in the middle, moderate barrier for slow to recognise patient readiness for mobilisation, poor interdisciplinary communication, and prioritisation of early mobilisation. As discussed earlier, early mobilisation in PICU is an emerging area of practice, and I think these responses indicate that staff aren't really sure how to assess a patient's readiness for early mobilisation, what is the best way for us to communicate about it, and where it sits in terms of priority for patient care. Staff felt the lack of recommendations and guidelines provided a more significant barrier, and this is something we plan to address with a follow-up research project. Staff were also invited to comment, and here are some of the reoccurring themes. Medical staff identified that early mobilisation is a multidisciplinary responsibility, which is absolutely the message coming from the literature and other resources. Some nursing staff thought it was just too hard, too many lines, too many people needed, not enough space in the unit, which I think fits with how some of the staff responded to early mobilisation as a priority for the unit. And a number of nursing and physio staff also identified that parental anxiety can be a major barrier too. So where to from here? We've obtained some funding for a research project for 2019 to develop a patient safety for mobilisation screening tool and a trial of multidisciplinary communication framework around this. This will include the development of some site-specific recommendations for early mobilisation, education materials for family, and multidisciplinary consultation and education. The overall aim is to increase the number of patients being mobilised and to assess the safety of the intervention. And that's me finished. Thank you, everyone.
Thank you, Catherine. Any questions?
Thank you for a great talk. We know that the adverse event rate for early mobilisation in adults is very low, so I was very interested in that early slide with nurses perceiving major barrier of vascular dislodgement, extubation. Do you have any data in your unit about safety events in the paediatric population? I know you're planning to look at it.
Yeah, not from our unit, and that's the objective for next year. So we'll be collecting data following physiotherapy treatments on any adverse events occurring with mobilisation. There certainly is paediatric literature evidence saying that it is safe and feasible, but at this stage the studies are quite small, so it's still very much in its infancy. Yeah.
Hi, Catherine. Excellent talk. My question is, following on from that you showed a slide of differences between nursing and physios with the risk of vascular dislodgement. Do you have any data with regards to the risk of extubation and the differences between nursing and physios there?
Yeah, actually, and I do. I did look at them separately, and I would have loved to put everything in. But again, physio accounted for the lower barriers. Yeah, they were much more, the responses, I think all of them that sat in the blue were all physiotherapy responses from memory. Yeah.
Thank you.
No worries.
Thanks, Catherine, for your excellent talk. That was great.